The thing that really got me excited is what you share, right? How it's generating data, and that data is going back to feed our AI training and decisioning process, right? So it's this virtuous cycle and delineating what the, is the data generated by human versus AI or augmented AI. It's a key part of what we have to do in Cohere, because the way we need to delineate the noise from the signal from the noise is quite different technique, right? Depending on how the data is being created. But go ahead, please. Yeah.
Yeah, and AG, your question just really got me some interesting memories there. So when we started to create our ModMed Scribe solution, we requested providers to record their patient-provider conversation to help us train the model, which obviously we were going to take the conversation, de-identify data, and then sort of use it for building. And once we started getting into the build mode and started listening to the audio, looking at the transcripts, so the conversation was, aha, how was your vacation in Hawaii? And oh my God, you have this spot there that looks not so good, but no clear indication of what was the diagnosis, what is the patient getting counseled on, or like, did you take the prescription that I prescribed last time? It's not something we can train the AI model on. The data quality you were talking about, and for us, was just not there. So we had to go on a roadshow to educate our providers on how to speak. And almost we were like, remember, AI is blind. So assume there is nobody in the room actually watching what you do, and you have to sort of speak in a way that a blind person can understand what is going on. So to you, that was one of the examples I thought I'll share.
Yeah, one of the examples for us, kind of similar use case, looking at clinical notes and really trying to extract entities so that it can be leveraged either for clinical decision support or even just to be a part of the medical record. We often say at IMO Health that medicine is an art as much as it is a science. And so the data that a lot of these large language models train from are publicly accessible data, right? Whether it's the coding standards that they're getting from like a UMLS as an example, or the clinical data maybe that they're getting from bits and pieces of some of these institutions. It's not comprehensive, it's not consistent. And so when you're looking at, for example, a note around family history, and you're seeing a patient who's coming in for chest pain, if you miss something like this patient has a family history of heart disease, that could be really impactful in terms of how this particular physician treats the patient and what clinical decision support workflows get kicked off. Similarly, around reimbursement, we're seeing that a lot of out-of-the-box models will identify kind of simple ICD-10 terms or codes, but there's so much complexity in how a clinician documents, and you'll start seeing things like a diabetes mellitus type 2 getting identified, but they're not putting together the long-term insulin dependency and the chronic kidney disease. So you end up having 3 separate codes where you could have had a single bill that was, double, triple the amount of reimbursement if you were to identify the term appropriately.